I would like to welcome now to this virtual studio of WEBIT Virtual, Dr. Ning Shen. Dr. Ning, I would like to have you with us and hopefully to hear from you the real story of what is going on in China. Hello, Dr. Ning, are you with us?
Yeah, hello, everyone.
Hello.
Good afternoon. So I need to share the screen. Sorry.
Please do.
It's a great honor for me to be here to share some Chinese experience. I'm Dr. Ning Shen from Peking University's Third Hospital. As you can see in Wuhan, which is in the central part of Hubei province, which is the worst city of COVID-19 at the beginning of this war. So, but there's a thing I want to mention to you because like you can see the case fatality rate. If in the Hubei province, that was about 4.7%. But if you see the number outside Hubei in China, you can see the case fatality rate is only 0.85. So I don't know why the mortality rate is such virus between China, but I think when you meet such situation, you need to be ready in the early time because we met so many severe and critical ill case in Wuhan, but in Beijing, I only saw a few cases, but they are all mild or moderate cases. So for the severe and the critical case, as the professor mentioned before, we only average about 20%. They may have severe or critical ill. For this part of patient, they did give us a big pressure for our doctors and nurses. As you can see, most of the patients have the respiratory distress and they have hypoxemia, and most of them need mechanical ventilation and need ICU care. And in our ordinary work, we think which things is most important for us is to how can we recognize this kind of patient in early time. So in our protocol, which released by our National Health Commission of China, they told us that if the peripheral blood lymphocyte decreased progressively, or the inflammatory factors such as IL-6 and CRP increased progressively, or the lactate increased progressively, or the chest image developed rapidly, then this kind of patients, they may have potential to become very severe or critical ill patient. And we also did some summary for our patient. You can see that we find that the age and the ferritin and the D-dimer, they can have some good prediction of the risk of mortality of our patient. And also this is a paper published in the Lancet, and you can see that the D-dimer and the lymphocyte count and the IL-6 and also the ferritin, etc., they may have some they may work as a predictor of the severe and the critical ill patient. For the treatment, I want to say we don't think there have any drugs which is good enough to be antivirals. Although we tried some medications, but they are not very good work on this kind of disease. So the most important treatment should be support treatment and also the monitoring. And also the most important thing for the severe and the critical ill patient is the oxygen therapy. and one of the most important thing is do the isolation. So last, I want to show you a case for one of our patients, and you may learn something from this case. This is a 62 years old male, and he got fever, cough, dyspnea, and diarrhea for 11 days. And at the beginning, the chest X-ray only show a little bit ground glass opacity in the lungs, and the vital sign at when he from the laboratory test, the indicator I mentioned before, you can see the lymphocyte is decreased progressively, and also the ferritin, the IL-6, and also the D-dimer increased. This is a bronchoscopy I did for him. And although we use all the kind of things like mechanical ventilation, steroids, and also we use some antibiotics and anticoagulation, but the patient still died. So what I want to say is that the critical cases who need ICU admission had very high mortality, and identifying these patients with poor prognosis at an early stage is really important. And I want to tell you because like today, China is in such a good situation, but we still worry about maybe we have some like something like the second wave or something like that. But since we do have some asymptomatic infected people, and they can be an infectious source, so always be careful, especially for the doctors and nurses and other healthcare workers. I think wear a mask is really, really important for all the healthcare professionals. And today, since it's a Qingming festival in China, and we actually did 3 minutes national mourning for all the people who died in the COVID-19. I hope we can this experience can be useful for all the doctors and nurses worldwide. Thank you.
I have a question for you. First of all, thank you so much for your presentation. It gives a very deep dive into what happened. I'm sure that we all have a lot of questions. My first question is in regards of, are you regularly using antibiotics for the COVID-19 patients, and which one, and what are the results?
Not really, because we don't think the bacteria is can do something with the COVID-19. And we did do some examination for the patient, and for the co-infection percentage is quite low. So we only give the antibiotic in some critical ill COVID-19 patient, because we cannot recognize whether they may have some bacteria, especially in the later stage when they have some intubation, and probably they may have some ventilator-associated pneumonia. Over.
Thank you. Shafi?
Yeah, so listen, thanks very much. Can we just explore the numbers a bit more? People worried about mortality rates, and across the world we hear different kind of levels of numbers, from those that enter intensive care, those that require ventilations. We've heard mortality rates of up to 86% in New Orleans, 70% in New York. In London, the first 200 cases are 50%. What's your understanding of the mortality and the outcome of your patients that go to intensive care, just to get a feel of that?
I really don't know the exactly number of the mortality rate in China, because we only worked in one ward in the Wuhan city. So I don't know the exactly number, but I think it's really, it will be high if the patient did have some invasive ventilation. I think probably maybe at least 30 or 40%. I'm not sure.
Okay.
Over.
The last question is around reinfection. People have mentioned a reinfection possibly happening anecdotally. Do we have any evidence of any reinfections that have come back to Wuhan, for example? Because you've been at the beginning of that infection, right?
Yeah, because this is a very hot topic in Wuhan now, because we don't think we do have some patients, they have reinfection, but we do have some patients when they get discharged from the hospital because in Wuhan, after they discharged from the hospital, they still need 2 weeks time isolation, and then they can go back home. But when they, after the 2 weeks time isolation, some patients, they did get some, the nucleic acid positive again. But I think some scientists, they did some test for this kind of patient. They don't think they have some transmission. They don't have some transmission because all this kind of patients, they did have the antibody. The IgG antibody are all positive. We think they have the protective function for all this kind of patients, but we still need, I think, more epidemiological study for all our COVID-19 patients, and then we can get the truly result.
Thank you. And one last quick question from me. The whole world is talking about PPE, personal protective equipment, and we were struggling to get the right equipment. Did China ever have problems with that? You seem to be much better at managing the protection of your staff than we have. What's the secret, or are we just missing that conversation? Did you struggle as well?
Yeah, actually at the beginning in Wuhan, we are very, very shortage of the PPE for the doctors, and you probably heard about that. We did have some doctors and nurses that got infected with the COVID-19. But after that, when we came to Wuhan, I came to Wuhan on February the 1st. After we arrived, since we asked the people all of the China, they worked for us, and they gathered a lot of PPE to Wuhan, and also a lot of Chinese people all over the world, they send something to Wuhan. So we now we are better and better. So you probably heard that there are about more than 40,000 doctors and nurses. We come to Wuhan to help to fight for the COVID-19, but none of us are infected. So it's a big work for our country. So
that's just amazing. 40,000 going to Wuhan to support the services. That's amazing in itself. Secondly, no infections amongst the doctors. That's just incredible. A lot to learn from how you've managed things. Look, we're so grateful for you staying so late with us. Thank you so much for sharing your thoughts. We'll go to our next speaker. And you are all heroes, by the way, for me. You are just amazing. So thank you. Plamen.
Thank you.
Absolutely. Absolutely. I can't say enough how much humbled and honored we are from having these amazing heroes with us. And what I'm really thinking of is that at the end of the day, after this obviously quite extended discussion we are having, we'll be hopefully a step further into understanding the truth about the COVID-19. I would like to move next, and please, Professor Zheng, stay with us. Because there will be a Q&A at the end of this discussion. So please don't leave us and stay with us. But we're going now next to our next participant.
Hello, everyone. I'm Chun-Hua Chi from Peking University First Hospital in China. Today, I will share some experiences with you on fighting against the COVID-19 in primary care in China. We have lost many lives in China, and we are so sad. We lost some excellent clinicians in China. I hope our lessons and experiences can help our international colleagues. I think community prevention and control is very, very important. If not, how can we reduce the totally cases and the deaths? We can see the right picture compared to the rescuing joining patients. Preventing joining is equally important. The first 2 weeks after Wuhan was locked, at the first stage, people didn't know how to deal with the pandemic. Wuhan was getting chaotic. More and more patients with fever went to hospitals. So community prevention and control measures is a crucial key important works in Wuhan and in China. National expert groups on community prevention and control divided into 13 groups, each group in charge of one administrative area respectively. All communities were closed strictly since 11 February 2020. Tight screening measures for these 4 categories of people that included confirmed cases, suspected cases, close contacts, and people with fever. The goal is that 100 hospitalization, screening, isolation, and treatment if people need it. But new challenge emerged. After the screening work, no enough beds for patients. The resolutions is that increase hospital beds, that increase existing hospitals, and there are 2 new hospitals and 16 Fangcang shelter hospitals built at a short time. So an important change came from patients waiting for bed to beds waiting for patients. That's a very important time. And we do some education work to promote health awareness and disease prevention knowledge for each household and each person nationwide that include wear mask and wash hands frequently, keep distances. So this knowledge we let all the household and each person know this. And up to now, the world should join hands to fight COVID-19. One important experience in China is that this should be a people's war because everyone is involved in it. Please act, fight to defend our family and homeland. Today is the traditional festival in China named Tomb Sweeping Day, half flag ceremony today for the whole country. We mourning for the martyrs and dead countries in the fight against COVID-19. And I want to experience my feelings for the whole world, for those clinicians who lost their lives in this fight.
Thank you very much.
Thank you.
And we do share.
I hope I can help you.
Sharing your knowledge is imminent and phenomenal help, but doing what you are doing in your role as Director of Department, General Practice, Peking University First Hospital, President-elect of the General Practice branch of Chinese Medical Association, and all other different verticals, initiatives that you're supporting and leading is really amazing. And I thank you for making time being with us. I would like to start with the questions for you. The first one would be, what are the mistakes that were made in fighting COVID-19 that other nations can benefit from?
I think, firstly, we should do more scientific research for this disease, because we don't know for a new disease at the beginning, people didn't know anything about it. And second is that I think GP in the community hospital should be take part in the.
Hear me?
Absolutely, Shafi. Welcome back.
Hi, sorry, I lost connection for a while, but I'm back now. One question, the great presentation. Thank you for sharing that with us, and also the Memorial Day today. Thank you for that. A lot of healthcare workers out there have given their lives, and other people. So it's great to see how China has respected those that have passed away. So thank you for that. My question is really around your rationalizing of care. In the UK at the moment, for example, our public health team and primary care are discussing rationalizing care. For example, it's suggested that anyone over the age of 70 or 75 will not be offered ventilation. It'd be palliation only. Anyone over 65 with chronic diseases like heart disease or respiratory failure will not be offered treatment either. And we're thinking about pushing that into practice. Did you have to make the same decisions for your patients out in China?
In China, some community hospitals don't care fewer patients at normal rural works, but at this pandemic disease, more and more community hospital, they manage so deep people in their community and do a important work for this prevention work. And GPs recent 1 month or more, they do pay attention to those people who with elderly and with chronic disease. These kind of people, GP in community, they will contact each person.
Okay. Thank you very much for that. Thank you so much for sharing your amazing knowledge. We're really honored to have you so late at night in China. So hopefully, thank you so much for that. Plamen.
Thank you.
It is even getting later because obviously the whole program expanded, but I'm not the one that will stop that flow of knowledge and experience coming to our international audience.
Plamen, one thing we could do at some stage, as this is a kind of a Memorial Day for China, we're having a clapping session once every week on a Thursday, 8 o'clock. It'd be nice to spend just a few minutes to clapping for all the people who lost their lives in healthcare, just as a community, to support their initiative before we go to the next speaker. Should we do that?
What a great idea.
Okay, so if we start clapping now, 1, 2, 3, go. For all the people out in the world. Thank you so much.
Thank you so much. Our next guest is already hopefully with us and hopefully with a good connection, Professor Zheng. Hello, Professor Zheng. How are you?
How are you?
Thank you for joining. I have already announced you before you rejoined again. Thanks God that you are with us now. I would like to request you to run your presentation and then we go for the Q&A section, if that's okay for you.
Okay, I will do the presentation for Professor JianJun, okay? And I'm gonna share my screen. Is that all right?
Please do.
Okay. Okay, good. Hello, everyone. I'm Dr. JianJun. So I'll talk about the value of low dosage CT scan. Hello, everyone. I'm Dr. JianJun. So I'll talk about the value of low dosage CT scan in the COVID-19 epidemic. So before we even talk about CT scan, I need to emphasize on transmission-based precaution, which is the precondition of every activity in hospital. And this is how we do a CT scan on probable and confirmed patients in our hospital. Here you see a staff get a proper PPE in blue area, and the patient movement will be restricted in these red areas, and there's no connection. There should be no connection between a CT scanner and the operating room. And we take a look at the CT imaging features. Everyone's know about it. We will see ground glass opacities, consolidation, and the thickened interlobular septa. And now we talk about this VP race, viral pneumonia reporting and data system. The whole idea of this CT-based system is our pursuit for an early identification of infection source. We found that compared with nucleic acid test or gene sequencing, CT scan obviously has a very high positive rate and a short waiting time. And throughout our practice, CT scan was widely recognized by experts in our region. However, we start to wonder, do clinicians really understand what we write in a report? Can CT scan, is there a way to put these words into numbers? Therefore, we came to this VP race system. And for this system, for radiologists, they could write an objective report and indicate a patient risk of having COVID-19. And for clinicians, they could understanding the CT report and get to know what to do. So the classification of VP race is based on 12 indicators and into 6 categories listed here. And we're gonna get through them. First is category 0. It means the chest CT scan cannot be fully assessed, mainly due to artifacts most of the time. And next, we have VP category 1. It means there's no acute lung extrusion or no specific findings. So those patients are quite fine. Also, we need to know that ground glass opacities may be found in certain patients, but if they do not change for 2 weeks, then it is still a VP1. And for VP category 2, there is acute pulmonary extrusion. However, in most cases, there's already an identified etiology. So like in this case, it's a bacteria-induced lobar pneumonia. And for category 3, there's also pulmonary extrusion. However, no identified contact history, no obvious etiology. And in this case, COVID-19 cannot be excluded, and further tests need to be performed. And for VP4 patients, there's a pulmonary extubation with confirmed contact history, and the clinical findings is suggesting a highly suspected COVID-19 patient. And you might think, well, everything's positive, so it's a positive case. But actually, we have some tricky cases. For example, in this case, the patient has typical imaging findings of the COVID-19, but the patient had 7 times of negative nucleic acid test, and it was only found positive on the 8th time. So we need to keep an eye on such patients carefully. And in clinical use, actually, we take VP3 and 4 as positive results, and these are the list of tests that needs to be done according to the classifications. And this is, and the hospital also included VP3 and 4 as the critical values. And in the end, looking back, we think it is efficient. However, there are controversies for staff exposure, individual radiation, but we believe the benefit outweigh the risk. Above all, we suppose low-dose CT scan and the VP race system is worth utilization in academic regions. So thank you all for listening. You're welcome to contact me for VP race details. Thank you. And I would like to pay sincere tribute to all the medical workers around the world.
Thank you. Thank you very much for this presentation. If you may stop sharing. And my first question is very straightforward. There were many doctors who died in China. What is the number?
I cannot tell you a specific number because I need to, if you really, you know, I do not have a specific number in my head right now. But I think you have talked about, you know, the Memorial Day today, everyone's loving them, hope them rest in peace. I think you know a lot about it now.
Can I ask a question as well? Hi, thanks so much for joining us, and thank you for sharing your knowledge and expertise. But we know that CT scans at the beginning were going to be the predictor of disease. And in fact, at the Nightingale Hospital that we're setting up in London has 4 scanners for imaging. So from your perspective, are X-rays just a waste of time? Is it straight to scan? And what's the criteria for you for patients that come to emergency? At what point do you scan them? Or does everybody get scanned if they go to hospital?
Okay, one moment. 就是说来到医院的人都要做吗？
有症状。那个是。
Okay.你讲，我来重新就 OK 了。
这是指的是一个疑似的病。
Okay, so in most cases we will do CT scans on suspected or to say probable cases.
Sorry, suspected cases.
Suspected cases.
So if the CT scan shows some abnormalities, and they have a poor predictor in terms of the findings on CT, will you automatically then fast track them to CPAP and ventilator, or do you still treat them as the symptoms develop? Do you have a policy of how that CT finding will then correlate very fast to treatment?
We do not direct link a imaging finding to a specific treatment, but we would ask the physicians to ask for an emergency disciplinary consultation. And the team will come out with the result on treatment.
Sure. And did you have problems with scanners? How many scanners do you have in the hospitals? Did you have a shortage, or were you okay with scanning people? Because you had huge numbers of people, right?
Oh, we have 7 CT scans, including the latest one that is mobile, so we do not have problems with the use of CTs.
That's good to hear. Thank you.
All right, I would like to invite now Stephen to go for the questions from his own and the audience that we have. Stephen.
Hello, everybody again. And actually, Professor Ahmed, let me start with one question for you, sir.
Okay.
You know, there are many inequalities in this world pre-existing this pandemic around race, ethnicity, age, so on and so forth. And many are talking about how the pandemic is exacerbating those differences. Are you seeing that in the UK at this time?
So it's a really good question. I think, look, the NHS here is fairly universal. We're trying to put in places to give people quality treatment up and down the country. We're opening new resources, new hospitals, planning capacity. So I think it's fairly uniform, I think, overall. Of course, there's rural areas that are not as well served, like most places around the world. My worry is around parts of the world that do not have the same facilities. So I was reading an article the other day, for example, Central African Republic, a country in Africa, has 5 million people, yet only 3 ventilators. It's unimaginable. So I think what's happening, of course, and this is a quote up on the other day, is that this is kind of the virus and the illness has no boundaries, but the actual, we have boundaries and walls amongst countries. So it's a kind of balance between, we know what it is, it's boundary-less, but we put up walls ourselves because of the inequalities of healthcare around the world. And that's, I think, going to be highlighted over the next few weeks as it spreads through parts of Africa and Asia.
Because we're certainly finding in the United States that the virus has no respect for any of those boundaries, but not everybody has the same access to healthcare, especially with limited testing and ventilators and so on. I'm going to ask a question to Dr. Chi, Professor Chi. Can someone in the back room let me know if Professor Shen is still with us, though? I'm not sure if she is. But Professor Chi, if you can hear me, I'm wondering what your understanding is about how long the virus can live on different kinds of surfaces, countertops, boxes, food packaging, because we're hearing a lot of different data here.
For my limited knowledge, I think the viruses can live for several minutes to maybe 2 days, within 2 days.
2 days.
In the different materials, it's lived for different times. The longest maybe in the metal surface.
Metal?
Yeah, metal surface, maybe they can live for 1 to 2 days. Other materials just for several hours.
Okay, because we're hearing here sometimes 3 days, sometimes as much as 17 days, and people are leaving their groceries outside. So it seems that's still a matter to learn more about.
Very interesting and important thing. I think someone should do some scientific, to research.
Yes.
Yeah.
We definitely need more data on many of these questions.
Yes.
Speaking of data, let me ask you one more question now. In terms of children and women who are pregnant, what kind of exposure rate and what kind of fatality rate? Are there any differences in those groups that you've seen in China, and how might have that changed in the period of time since the pandemic started?
Children, we just suggest that children should stay at home, because for children, I think no face mask can be for them to use. And children, if they are so younger, their parents can't manage them very well out of their families, I think. So I think children should stay at home. Yeah.
Thank you very much. Thank you all very much.
Indeed. Thank you so much, Stephen. And thank you all so much for this very thoughtful and honest discussion that we had on the issues that we are all facing. And I think we can learn a lot from the knowledge and know-how that our guests from China shared. I think we know exactly what is happening now in Italy, and we've heard it from the person who is at the forefront of that, Professor Cecconi. Thank you very much, Professor Shafi Ahmed.
My pleasure. Thank you, Plamen.
And look forward to stay in touch. Everyone, thank you so much for being with us. It's been much longer than expected, but for a start, I believe we gave, let's say, the taste of what WEBIT Virtual is going to be. Hopefully next time we shall be in a position to bring the packaging of the whole television, and the upcoming edition with Raja Rajamanar, the Chief Marketing Officer of MasterCard and President Healthcare of MasterCard, with truly amazing speakers, will be the official premiere. Thank you all, really. Thank you for being with us, and look forward to stay in touch. Be safe, stay healthy. And again, it's not about leadership anymore. It's about stewardship, and it's about us. Looking forward to keep and grow that community together. Thank you.